Welcome to the webinar Landmarks for Immigrants and Refugees Counseling. In terms of measures applied in Romania to facilitate immigrants and refugees' social integration, we have the Ordinance 44 from 2004 on social integration of foreigners who have gained a form of protection or a right to stay in Romania, as well as the citizen of the European Union and the European Economic Area, which states that the social integration is the process by which foreigners participate in an active way to the economic, social, and cultural life in the Romanian society, in order to prevent and fight against marginalization and to help them adapt to the conditions of the society in Romania. Support for social integration covers mainly persons with a form of international protection, but it is also accessible, at least at legislative level, in all its forms to other aliens with a legal stay. If, for example, they approach the regional office for employment, other aliens with a legal stay may benefit from individual mediation plans for getting in contact with employers. There are three types of support which are offered to immigrants and refugees in Romania. First, there is cultural familiarization, which is the responsibility of the General Inspectorate for Immigration. Then there are services of counseling and, of course, Romanian language courses organized by county school inspectorates in cooperation with the General Inspectorate for Immigration. We are going to present now some of the principles of multicultural adequate psychological services practice stated by the American Psychological Association, which can be used also in other types of social services offered to immigrants and refugees. Professionals are encouraged to admit that themselves may have culturally determined attitudes and beliefs, which can have a negative influence both on the way in which they perceive individuals who are different from them and on the interactions they engage with those individuals. Professionals are encouraged to develop cultural competence involving the use of appropriate cultural knowledge, positive attitudes toward culturally different clients, and the use of culturally appropriate interventions. Theorists of different orientations, psychodynamic, cognitive, behavioral, or humanistic, have all called in recent years for the integration of issues of social cultural context into conceptualization and intervention in these cases. Further, professionals are encouraged to use the constructs of multiculturalism and diversity both in the educational practice or when they conduct research. Research on culturally adapted interventions indicates that interventions in clients' native languages are more effective than those conducted in English, that culturally adapted interventions are more effective than those not targeted to specific cultural groups, and that ethnic matching in the therapeutical diet is likely to improve client retention and therapeutic outcomes. When immigrants do require clinical treatment, a resilience and coping perspective is important to incorporate into the treatment process. Some immigrants may draw strength from family structures that Western therapists may judge negatively or misunderstand. So it is important to understand that something that might be considered a strength in one cultural context may be considered undesirable in another. There are 5 categories of challenges facing immigrants. First, there are challenges related to the immigration process. Then are challenges related to the job or the loss of the occupational status from the country of origin. Third, they can be traumatic experience that one immigrant or refugee can experience. Then the acculturation process and the discrimination and racism one could experience. In terms of stress involved in the immigration experience, it can cause or exacerbate mental health difficulties, including anxiety, depression, post traumatic stress disorder, or other mental health issues. Loss of occupational status, on the other hand, can lead to feelings of frustration, uselessness, and anger. And meaningful employment can help the immigrant adjustment process by decreasing feelings of isolation and contributing to the building of new social networks, providing opportunities for new friendships, developing language skills, or offering new information about the culture in which the immigrant is living now. Trauma-based problems include pre-migration trauma or experience of deportation after having arrived in one country, inadequate living conditions, lack of social support, feelings of persecution and distrust of authorities and institutions. Traumatic experiences of children and youngsters can have a strong impact. Examples of such are raids and unannounced checkings of the family members, or separation from the family members, placement in detention camps or child protection centers, if not deportation. Acculturation involves changes in many aspects of immigrants' lives, including language, values, social customs, and gender roles or media use. The process of integrating the social and cultural values, beliefs, and behaviors from the culture of origin with those of the new culture can lead to acculturative stress if they conflict. Intergenerational conflicts are common in many immigrant households. Acculturative conflicts are sometimes at the root of what brings immigrant families into counseling. In some cases, second generation children or teenagers may experience role reversal when they are in a position to translate for their parents or to help them navigate the culture of the new country. Older adult immigrants are often the most vulnerable to mental health problems, with the exception of victims of warfare and torture. Some immigrants may view self help as the best way of dealing with mental health problems, or may not understand how psychological problems can be treated from a Western perspective. Others may prefer alternative sources of help rooted in their cultural origin, be they priests or imams. Some of the social cultural barriers in accessing counseling or mental health services by immigrants are different perspectives on the causes of mental health problems or on the way to cope with these problems, and the stigmatization associated with mental health problems. There are also contextual structural barriers in accessing counseling or mental health services, like the lack of adequate services or the difficulty of finding interpreters, or the absence of persons prepared to work with ethnic minority groups or with elder persons from different culture. Also, the lack of information regarding the mental health services and resources. The political context of the adopted country can affect immigrants, adults, or children's sense of safety and belonging and their ability to trust that systems of care will help them when they are facing mental health challenges. Unauthorized immigrants face additional challenges related to documentation status, and some have a fear related to accessing these services. Immigrants in rural areas may face additional barriers, including lack of access to culturally competent service providers. For example, a psychologist might downplay the role of religion and spirituality in the client's life and overemphasize autonomy and independence as therapeutical goals, failing to take into account the client's cultural values. For example, obstacles in immigrants' psychological assessing and diagnosis are related to the lack of instrument standardized translations. One difficulty in the assessment of immigrants is the lack of valid and culturally appropriate diagnostic tools that recognize cultural differences in the expression and coping with psychological distress. Clinicians can benefit by using multiple sources of evidence when assessing immigrant clients and identifying culture specific expressions of well being and distress. It is important that clinicians examine their own biases and expectations that may affect the assessment process. They should also consult with colleagues and supervisors who may be more familiar with the client's social-cultural context. Other obstacles in immigrants' psychological evaluation and diagnosis are clinicians' failure to assess resilience and the complications that appear when assessment is not conducted in the native language and when you need a translator present in the counseling session. Some of the good practices in assessing and diagnosing immigrants stated by the American Psychological Association are analyzing cultural and linguistic differences between clients and dominant culture, using culturally adapted versions of assessment methods and tools, and recognizing the dynamic nature of culture and incorporating cultural variables as central elements in all phases of the evaluation process. Other good practices in assessing and diagnosing immigrants are assessment by cultural sensitive interviews designed to collect information about language, religious practices, racism and prejudice, cultural values. taking into account the clinician's biases and assumptions, and taking into consideration the conditions and circumstances in which evaluation takes place, as well as the present and future implications of the client's testing and diagnosing. A good practitioner who works with immigrants and refugees takes into account that disorders fit within a continuum and works together with a translator in order to cross the language barrier, collaborates with family and community members when this is appropriate, and consults with his colleagues or with his supervisor. To increase the accessibility and efficacy of services, clinicians or practitioners from different social services should adhere to the following guiding principles proposed by the American Psychological Association. First, integrating evidence-based practice with practice-based evidence. Second, provide an efficient treatment considering culture. Third, work in partnership with community organizations. And fourth, take into account the principles of an approach based on social justice. Community organizations offer services for mental health issues, legal counseling, social assistance, or educational services. They are situated in areas where most immigrants in the target population live, and these organizations help improve access to health services. Educational settings have been identified as particularly effective sites from which to provide mental health services to immigrant children and their families. Stigma surrounding mental health services can be reduced when such services are provided as an educationally connected intervention in a safe and familiar settings, and schools have natural access to families who may be otherwise reluctant to seek mental health services for their children in more traditional settings. The social justice perspective states that all people have the right to equal treatment, fair allocation of the resources of society, and participation in decision making. Psychologists, on the other hand, can contribute to the development of a better society by counteracting systematic inequalities, because therapeutical interventions can be designed to help individuals change both themselves and the conditions contributing to the problems that they are facing. When working with immigrants, competent social services providers take into consideration pre-migration factors, the migration experience, the possible related trauma of the admission in the new environment. They try to enhance their communication skills, and they take into consideration changes of gender roles and intergenerational problems and the economic stress and possible marginalization. Employees working in immigrants and refugees camps need to have clinical abilities in order to recognize the signs of post-traumatic stress syndrome and of depression. They need clinical abilities to counteract the stigma associated with mental disorders, to manage clients' attacks of panic, and to recognize and reduce the risk of suicide. Employees working in immigrant and refugees camp also need management skills to share professional practices and knowledge, to distribute cases and to work in case management with more than one service provider, to establish protocols when working with refugees in a crisis situation, and to find and access mental health resources for clients. Employees working in immigrant and refugees camps also need general knowledge about the system of mental health, how it works, general knowledge about parenting, child discipline, and child related legislation, and general knowledge about pre migration living conditions and refugees' life experiences. What should employees working in immigrants and refugees camps do? They should engage in field activities in refugee communities. They should improve their abilities to manage cultural aspects as well as the ability to provide culturally adapted services. They should improve and refine their abilities to interpret and understand the clients. They should learn about refugees' mental health problems. And they should learn about the situation in the refugees' country of origin. Additional recommendations are that employees working in immigrants and refugees camps should seek the help of refugees who are in a better state and involve them, and engage professionals with a better expertise in traumatology when there is a need for such professionals. Now, I will invite you to think, what could you do in a situation in which the client does not express directly their needs related to mental health, or when there is a different culture of mental health. The client feels sad, or the client is angry because of some unfulfilled expectations. And we are talking now about clients who are immigrants or refugees. I will allow you a minute or two to think, what can we do in these situations? You will have the chance to address these examples after the recorded webinar ends with my colleague, with Violeta Rotarescu. But let me give you a couple of clues. For example, in the situation in which the clients, the immigrants, the refugees do not express directly their needs related to mental health, or maybe there is a different culture of mental health, one should try to understand the different items of distress that the client may use to express mental distress indirectly. For example, service providers have reported hearing clients say that they have a heavy heart, a heart that hurts, a mind full of troubles, or that it is difficult to sleep. Talking about what this means to the client can be helpful. It builds rapport, it conveys to the client that you understand what they are saying and specifies understanding of the need. And in some cases, it can model a vocabulary that your client can use in the new country when they will need to advocate for their needs. What about when the client feels sad? What can we do then? Being homesick is not a mental disorder, but serious mental distress may develop. Be aware of changes in your client. Learn to recognize signs that may indicate bigger problems, such as depression, which can coexist with post-traumatic stress. And we will talk a little bit this further on. For example, signs like sleeping too much or maybe sleeping too little, changes in eating patterns, irritability, withdrawal, or a loss of interest in activities that were previously enjoyed by your client. If you see signs of depression, you need to be careful and to address concerns about possible suicide promptly if you see that showing up. What about the situation in which the client is angry because of some unfulfilled expectations? Well, you need to talk with your immigrant or refugee client about their expectations, their hopes, and their achievements. You need to help him or her identify where they have had success since arriving, what challenges remain, and the areas where they can make plans and set goals. Focus on where the client has demonstrated resiliency or strength. Approaches such as strength-based therapy may be helpful. For those moments of loss or perceived failure, work with the client on strategies for coping with accompanying stress or anger. Also encourage the client to engage in activities that they enjoy and build a social network. We are going to talk now about post-traumatic stress syndrome or trauma. Shocking and overwhelming events or experiences involving a major threat at the well-being and physical, emotional safety of the victim and or victim's dear ones. Trauma's original occurrence is usually sudden and unexpected. It may be a one-time event. In some cases, after the first incident, it may recur on either a short-term or intermittent basis, or it may occur on a regular or prolonged basis to the point of becoming continuous and chronic. Examples of traumatic events include military combat, acts of terror, auto accidents, natural or human-caused disasters and accidents, sudden or violent death of loved ones, interpersonal violence such as mass shootings, assaults, and physical, sexual, and emotional abuse, traumatic separations, and other significant losses like neglect, abandonment, hostage taking, torture, slavery, certain types of illnesses of medical treatment, especially for life-threatening conditions. I think you have identified from the list I have just mentioned which are some of the traumas that people that have migrated could have encountered during their migration, previous to their migration, during their migration, or post migration. Exposure to traumatic events may occur through direct experiences as an eyewitness, through information about an experience of a family member or another close person, or through repeated contact due to work with details regarding traumatic events. The first DSM-5 criteria for post-traumatic stress syndrome is exposure to a traumatic event. The second criteria is presence of one or more intrusive symptoms associated to the traumatic event that start after the event occurred, like 1. Disturbing, intrusive, and recurrent and involuntary memories about the event. 2. Recurrent disturbing dreams, the content of which is related to the event. 3. Dissociative reactions, flashbacks, in which the individual feels or behaves as if the event was occurring again. 4. Intense or prolonged psychological distress or following exposure to internal or external stimuli that symbolize or are similar to an aspect of the traumatic event. 5. Strong physiological reactions to internal or external stimuli that symbolize or are similar to an aspect of the traumatic event. Third criteria is persistent avoidance of stimuli associated to the traumatic event, as indicated by one or both types of behaviors below. 1. Avoiding or the effort of avoiding disturbing memories, thoughts, or emotions about or closely related to the traumatic event. 2. Avoiding or the effort of avoiding external stimuli, people, places, conversations, activities, objects, situations, arising disturbing memories, thoughts, or emotions about or closely related to the traumatic event. Another criteria are negative changes at cognition and dispositional level associated with the traumatic event beginning or worsening after the event occurs, as is indicated by two or more of the following symptoms. 1. Incapacity to remember an important fact related to the traumatic event. 2. Exaggerated and persistent expectations or beliefs about oneself, others, and the world. 3. Persistent distorted cognitions about the cause or consequences of the traumatic event that make the individual blame himself, herself, or others. 4. Persistent negative emotional state, fear, horror, anger, guilt, or shame. 5. Significantly diminished interest or participation in important activities. 6. Feelings of detachment or estrangement from others. 7. persistent incapacity to feel positive emotions, like the example, the incapacity to feel happiness, satisfaction, or love. There are also significant changes at the level of excitation or reactivity associated to the traumatic event, beginning or worsening after the event has taken place, as indicated by two or more of the following symptoms. 1. Irritable behavior or anger fits with reduced or inexistent provocation, generally expressed as verbal or physical aggression to people or objects. 2. Reckless or self-destructive behavior. 3. Hypervigilance. 4. Exaggerated startlets. 5. Concentration problems. 6. Sleep disorders, like difficulty in falling asleep, staying asleep, or unquiet sleep. The last criterias are that duration of disorder is longer than 1 month, that the disorder generates distress or a clinically significant deterioration at social, occupational level, or in other important operational areas. And last, the disorder cannot be assigned to the physiological effects of a substance like medication or alcohol or another medical condition. We have reached the end of the webinar. If you want to read further on, I invite you to access the resources presented on this website and read more, because there are many more resources available for those practitioners that want to improve their skills and raise their awareness on how to better offer services to immigrants and refugees with whom they work. It is a challenging work, also full of rewards and meaning. If you have questions, my colleague Violetta will moderate the webinar from now on. I want to thank you for listening to this recorded webinar, and I hope it was useful in trying to sum up both principles of multicultural practice, the abilities required when working with refugees and immigrants, and the information provided in trying to recognize signs of trauma in order for you to refer those clients that you see with these symptoms to mental health professionals specialized in working with trauma. Thank you very much. I hope you enjoyed this webinar and continue this conversation with my colleague Violetta.